Hello everyone. I hope that you all are doing fine, and I hope that my videos are helpful for you and you are getting some help from these videos. And we have covered so much important topics so far, like the caries or the periodontal or even the antibiotic topic. So in the history taking, so these are also very important. So even like in short, at each and every word or each and every line given in this book is very very important according to your exam point of view. And today we are going to start this important topic, which is the acute odontogenic infection. And there would be two or three scenarios from this chapter only. So you should be very thorough with this chapter. And yeah, so let's start and let's see how we go. Okay, and if you like my videos, you please do subscribe and and share with your friends. I would be very grateful for that. Okay, so let's start with the acute odontogenic infection. Acute odontogenic infection, odontogenic means tooth-related infections, right? Are common and it can affect the dental pulp, which is like what are the ways how these can happen? The odontogenic infection. Okay, so first way is that it can spread through the pulp. How can a pulp involved in the infections? Either firstly secondary to restoration breakdown, the patient has got any filling done and there is micro leakage or there is a gap in between the tooth and the restoration from where the bacteria are getting inside and that are leading to secondary decay, which has led to the pulp infection. Or the primary decay, which is the dental caries or loss of tooth structure from trauma. So these are the several ways from how a pulp can get involved in the infections. And the other ways to cause the odontogenic infection is the periodontal tissues, and it is most commonly due to advanced periodontitis. So, if the patient has advanced form of periodontitis, as we studied in the last class, that the periodontal abscesses very rarely they do spread into the spaces, but if they do, then you need to treat them as acute odontogenic infection, and they mostly occur in patient who already has a history of periodontitis. And then the pericorneal tissues. Most commonly, it happens with the partially erupted mandibular third molars. If an odontogenic infection is ignored or not appropriately treated, it can progress to a localized abscess. So these are the staging how the infection spread. Like first of all, there would be reversible pulpitis, then irreversible pulpitis, then then apical periodontitis, and then there would be an infection which is the abscess, which would be localized, and later it could spread to the soft tissue if not treated on time. Rare but serious complications include Ludwig angina, air compromise, sepsis, or spread to the bone, brain, or neck, or even the heart. It can occur, and it is very dangerous situation. So you would be treating the patient whose infection has spread onto the face. You can treat them by doing the active dental treatment and by prescribing them the oral antibiotic, but if there is a serious complications like these ones, then you won't be able to help the patient with the oral antibiotics. Then the best treatment would be done in the hospital, which include IV antibiotics and the urgent treatment. And in the immunocompromised patients, it means that the patient who has low immunity are more prone to rapidly spreading infections. Persistent dental pain and swelling after dental alveolar surgery could be due to so if you did the treatment for any patient and patient comes back with the pain, so there could be few reasons why he is in pain. First of all, which is most common, is the alveolar osteitis, which is also commonly known as dry socket, and the other reason could be that there is a post operative infection at that site. Osteomyelitis of the jaw is an important differential diagnosis in patients with an unresolved oral infection with systemic features and localized bone pain or tenderness. So, if your patient complains about oral infection which is not going away even with the dental treatment or with the antibiotics, and there are systemic features which include there is fever and there is localized bone pain or tenderness, then if osteomyelitis of the jaw is suspected, refer the patient to hospital. Expert advice is needed. Differential diagnoses include osteonecrosis and osteoradionecrosis. Then approach to managing acute odontogenic infection. An acute odontogenic infection requires prompt management with the dental treatment, which means the most important thing to treat any infection or treat any problem is the active dental treatment, which would be either taking the tooth out or taking the infected or diseased nerve out, or surgical intervention to address the source of infection. Antibiotic therapy is not a substitute for dental treatment but may be required if dental treatment is not likely to be received within 24 hours. Whether the patient can be managed in the community or requires hospital admission depends on the severity of the infection. Seek expert advice for patients with recurrent infection who have received antibiotics but not dental treatment. So, if the patient is coming to you and he is getting the infection again and again, so there is recurrent infection, but he has not got any dental treatment, but he has completed the course of antibiotic, then you can seek expert advice on that, because antibiotics is not a substitute, that's understandable, but it should help, right? So it should help in lowering down the infection. So even after completing the dose of antibiotics, still there is an active infection, then you need to find out whether the patient's body's immunity is low or what is the really cause of it, so you can ask for expert advice in those cases. Then odontogenic infection is usually it is polymicrobial involving anaerobic and aerobic oral bacteria, and metronidazole is used in conjunction with the penicillin, because like penicillin would act against aerobic and metronidazole would act against anaerobic. Because of increased rates of resistance to penicillins in some oral bacteria, which is Prevotella oralis. However, amoxicillin plus clavulanate has adequate anaerobic activity, so can be used. So there is two options for you in case of odontogenic infection. Either you can prescribe the patient metronidazole plus penicillin, or you can prescribe amoxicillin plus clavulanate. Okay, so this is very important table that you need to learn and to understand what is the stage of infection in your patient. So the localized odontogenic infection, it means there is pain, which is tooth related dental pain, and there is abscess, which is abscess means localized swelling on the gum or fluctuant tissue. Okay, and pus may be visible. So there is pain. Patient would complain about the pain from the tooth. There is gum pimple, and the pus is coming out from that pimple, but there are no other signs of facial swelling or any systemic. So just learn the positive finding, which is the dental pain, gum abscess, and the pus is coming out. Then what would be the management of these patients is the outpatient dental treatment. It means you need to do the active dental treatment, either taking the nerve of the tooth out or taking the tooth itself out. But in case if dental treatment is not likely to be received within 24 hours, medical practitioners can start antibiotic therapy. For example, this patient visited the GP, like he hasn't come to you and there is a waiting period of 24 hours, then the GP can prescribe the oral antibiotics. However, ensure the patient receives dental treatment, because that is the most important uh, therapy for the localized odontogenic infection. Okay. Then the second stage is spreading odontogenic infections without severe or systemic features. So it means the infection is spreading now. How do infections spread? Through the spaces. So that is leading to facial swelling. And the other things are same. So there is dental or facial pain, there is abscess, there is pus, and plus what is the additional positive finding in spreading infection, which is the facial swelling. Okay. So what you need to do for these patients, you need to treat them as outpatient dental treatment by doing the active dental treatment. Plus, you need to prescribe them some antibiotic to take home. Okay. And if the dental treatment is not likely to be received within 24 hours, medical practitioners can start antibiotic therapy. However, ensure the patient receives dental treatment. So here we are only doing the active dental treatment. Here you, because there is facial swelling, so you need to prescribe the antibiotics as well after doing the active dental treatment. But if in your case the patient has spreading odontogenic infection with severe or systemic features, which are the severe features? It means that there is significant amount of facial swelling and there is significant amount of pain. Patient cannot open his mouth completely, and there is neck swelling, difficulty swallowing, difficulty breathing, or airway compromise. These are the severe features. And what are the systemic features? Systemic means there is pallor in the body, sweating, tachycardia, and axillary temperature above 38 degrees Celsius, or there is sepsis. Okay, so if these features are present in your patient, then you need to provide appropriate support if has difficulty in airway and breathing or circulation, and you need to transfer him urgently to the hospital with an oral and maxillofacial surgeon or another appropriate expert. So you need to refer your patient urgently to that hospital that has oral and maxillofacial surgeon in it. Okay, because the treatment for this one would be surgical intervention and intravenous antibiotic therapy. And for checking the temperature, temperatures are unreliable for infections originating in the mouth. So you need to check the axillary temperature. Then the localized odontogenic infections. An odontogenic infection is considered to be localized if it causes dental pain without facial swelling or systemic feature, as we read it here. Local odontogenic infections it can come from either the pulp, so it would lead to periapical infection, or it could come from the pericorneal tissue, then it would lead to pericorneal infection or the periodontal abscess. Okay, signs of abscess include there would be visible pus, there would be localized swelling on the gum or fluctuant tissue. However, dental pain may be the only sign of a periapical abscess. Then because in the periapical abscess, this won't be, we cannot localize and we cannot see any pus coming out. So for periapical abscess, the only sign could be the dental pain. Then the key to successful management of localized odontogenic infection is dental treatment to drain pus and address the source of infection. So what is the best treatment for the localized infection? Is the dental treatment, in which you would need to drain the pus and address what is the source of infection. Why is this infection occurring in the patient? For example, if it is periapical abscess, so you need to clean the pulp and start the endodontic treatment, or need to take the tooth out. Okay. Antibiotic therapy is not required because dental treatment removes the source of infection and bacteremia caused by treatment resolves rapidly. Do not routinely give antibiotic therapy after dental treatment for a localized odontogenic infection. So there is no need to give the antibiotic therapy in localized infection. However, if an infected tooth breaks during an extraction and there is a delay in removing residual root or bone fragments, antibiotic therapy is indicated. For example, there is a scenario like patient has got periapical abscess, okay, and the patient opt for extraction. So patient wants extraction, so we need to take this tooth out. But while doing the extraction, so there was some complication and this root is left inside. So this part is still inside and this part of the tooth is out, and there is a delay. There is a delay means you are not competent enough to do the surgical extraction, or you are not competent enough to take this root part out. Then you may need, yeah, then you would need to prescribe the antibiotic therapy to the patient. And which antibiotic you need to prescribe is, we will see on page number 83, this one. If the tooth is not infected, antibiotic therapy is not required. Okay, so for example, if this root part was, if the tooth was not infected to start with, there was no infection in the root part, then you do not need to prescribe the antibiotic. But if there is infection, then you need to prescribe the antibiotic to the patient. This is a bit controversial when it comes to the exam point of view, but just keep in mind, if there is any infection in the tooth, or you can see in the x-ray, or there is any point that they have mentioned that there was an infection, then you must need to prescribe the antibiotic to the patient. Patients with localized odontogenic infection may present to a medical practitioner and promptly refer the patient to a dentist for treatment. If dental treatment is not likely to be received within 24 hours, then they need to start the antibiotic therapy. However, antibiotic therapy is not a substitute for dental treatment, so ensure the patient sees a dentist. Offer systemic analgesic because patient would be in pain, then you need to prescribe, or the GP would prescribe the painkillers to the patient for the pain. For pericorneal infection, the best treatment is irrigate the area with the sterile saline solution and recommend rinsing with warm saline or chlorhexidine mouthwash until dental treatment can take place. Okay, and what would be the best dental treatment for each condition? If there is periapical abscess, then the patient have two options: either to go for root canal treatment or the extraction. If the patient has periodontal abscess, then we can do the debridement by doing the scaling, or he may opt for extraction. But in very rare case where the abscess has gone deep down and it is must requirement to take the tooth out to drain the abscess completely, then the pericorneal infection would include abscess. So for the pericorneal infection, the best treatment of choice would be the extraction. And the other option which we can opt for is removing or recontouring the opposing tooth, which is the upper third molar. So we can also do the also try to take out that tooth, because that is the reason why it is leading to a pericorneal infection in that area. But the best treatment of choice is to take this that tooth out, the mandibular third molar out. Then the next topic is spreading odontogenic infections without severe or systemic features. So, spreading odontogenic infection that has caused facial swelling but no severe or systemic feature. So, there is facial swelling but there is no systemic or severe feature. It can be managed in an outpatient, like as a general dentist, you can manage these patients. What would be your management? You need to drain the pus and send it for the culture and susceptibility testing. Then the other treatment, the next step would be the surgical or dental treatment. Either you can start the root canal first stage, or you may, if the infection is coming from the pulp, if the patient is coming from the gums, then you can do the periodontal treatment, or you can take the tooth out if it is grossly decayed or whatever the situation would be, to address the source of infection. Then the third point is you need to prescribe the oral antibiotic therapy. Ideally started after samples are taken for culture, because here there is facial swelling, so this is the additional point that you need to do. Okay. It may not be possible to achieve adequate analgesia with local anesthetics in patients with spreading odontogenic infection, because if there is an infection in that area, so the local anesthesia does not really work well in that area if there is infection due to the acidity of the infection. However, this should not delay the dental treatment. What other approaches you can try? First of all, you can give, I think, sufficient amount of LA to the patient. You can give him more LA, or there are certain other strategies which include the anxiolysis, which means the minimal sedation technique. Or you can try the general anesthesia may be required. Once the source of infection has been addressed, then start the antibiotic therapy. Patient with spreading or odontogenic infection may present to a GP. So for the GP, they need to refer the patient promptly for the dentist to the dentist. If dental treatment is not likely to be received within 24 hours, then start the antibiotic therapy. However, antibiotic therapy is not a substitute for dental treatment, so ensure the patient sees a dentist. Offer systemic analgesics for the treatment of dental pain. For antibiotic therapy of spreading odontogenic infections without systemic or severe feature, which antibiotics you need to prescribe to these patients is metronidazole 400 milligram orally, 12 hourly for 5 days, plus either you can prescribe this penicillin, which is the phenoxymethyl penicillin. It is narrow spectrum, so you can prescribe either this one or the moderate spectrum, which is the amoxicillin 500 milligram. You need to remember the doses. Or you can prescribe amoxicillin plus clavulanate. From both of these, you can prescribe any. And if the patient is sensitive to the penicillin, then you need to prescribe clindamycin 300 milligram orally, 8 hourly for 5 days. Review the patient 48 to 72 hours, which means after 2 to 3 days, you need to review your patient and check and after starting treatment to check response. Advise the patient to seek prompt dental review if their condition deteriorates and if the infection has not resolved within 5 days. So you need to ask your patient to come back or to seek a review if it is not helping. Then, if the infection has not responded to treatment, ensure the source of infection has been addressed. If the infection is not responding to your treatment, then you need to find out whether you have taken out the correct tooth or whether you have identified was the actual source of infection. Then, pus was drained adequately. You can try to do the computer tomography, may be required to check for locules if the drainage was complete. The infection is susceptible to the current antibiotic regime. If the infection results of culture and susceptibility testings are available, then modify the antibiotic therapy accordingly. So these could be few of the reason why the infection has not resolved. So you need to find out whichever is in your case. Then failing this, or if the patient's condition has deteriorated, then even after doing these 3 steps, your patient is not responding, then seek expert advice from an oral and maxillofacial surgeon. Transfer to an inpatient facility may be required. So inpatient would be the hospital setting. Then spreading odontogenic infections with severe or systemic feature. Severe features of a spreading odontogenic infection include significant facial swelling and pain, trismus, swelling of the neck, difficulty swallowing, and difficulty breathing. Systemic feature would include pallor, sweating, tachycardia, auxiliary temperature above 38 degrees Celsius. The infection can rapidly become life-threatening because of the risk of airway obstruction and sepsis. Ludwig angina is a severe spreading infection involving bilateral submandibular, sublingual, and submental spaces with cellulitis. Arrange urgent transfer of patient who has a spreading infection with severe or systemic feature to a hospital that has an oral and maxillofacial surgeon or another appropriate expert. Okay, so you need to refer your patient urgently to the hospital who has oral and maxillofacial surgeon. Then what would be the management for these patients? First of all, they would maintain their patent airway, which is do not lie the patient flat, resuscitation, draining pus by incising affected spaces and placing drains, removing the tooth or otherwise addressing the source of infection, obtaining blood and other samples for culture and susceptibility testing, and they would start the IV antibiotic therapy. Spreading odontogenic infections can be associated with sepsis. For patients with sepsis, start antibiotic therapy within 1 hour of the presentation to a medical care. Antibiotics should be given immediately after appropriate samples are taken for culture. Obtain blood samples and other relevant samples as soon as possible, but not if doing so will delay antibiotic administration. So for these patients, what you can do is you just need to refer them urgently to the hospital who has oral and maxillofacial surgeon, because this management you won't be able to perform in outpatient setting. For empirical antibiotic therapy of spreading odontogenic infection with severe or systemic feature in conjunction with surgical intervention, use which antibiotic they use is the benzyl penicillin IV. If they require intensive care support, then 2.4 gram dose, and if they do not require it, then 1.8 gram plus metronidazole 500 milligram IV 12 hourly, or the amoxicillin plus clavulin dose. If the patient has got immediate non-severe or delayed non-severe, then they do prescribe cefazolin 2 gram plus metronidazole. But if the patient has severe hypersensitivity, then they do give clindamycin 600 milligram IV. So if you are prescribing orally, then the clindamycin dose is 300 milligram, IV dose is 600 milligram. Lincomycin 600 milligram IV 8 hourly. Modified therapy based on the results of culture and susceptibility testing. Switch to oral therapy once swelling and trismus subsides. So when you need to switch the therapy to the oral, once the swelling and trismus has subsided and the patient can swallow and purulent discharge from the drain slows. If results of susceptibility testing are not available for oral continuation therapy, use the appropriate regime. Stop oral antibiotic therapy once the drains are not producing any purulent discharge. Signs and symptoms have resolved. The white cell count has returned to normal and the patient is afebrile. So when you need to modify to oral, when the swelling is subsiding, trismus is subsiding, and the patient can swallow now, and the discharge is slows down. When you need to stop the oral antibiotic therapy, when there is no discharge, the patient has no fever and his blood cell count is normal. Then infection following dentoalveolar surgery, which means post-operative infection. The infection following dentoalveolar surgery, for example, if after the tooth extraction or implant placement or any associated procedure, is very uncommon, and its incidence is not reduced if even if you prescribe the surgical antibiotic prophylaxis, which means before performing the procedure you prescribe him single dose of antibiotic. It would not help in preventing the post surgical infection. Before diagnosing post-operative dental infection, exclude post-surgical inflammation and alveolar osteitis. Signs and symptoms of the post-operative dental infection include there would be cellulitis adjacent to the surgical site. The area would be fluctuant. There would be purulent discharge. There would be pain and swelling that is worsening or is not improving 48 hours after surgery. Okay. So it means there is cellulitis, fluctuant, there is discharge which is coming out, there is pain, and the area has swelling. If post-operative dental infection is not associated with severe feature, which were the severe feature, which were significant facial swelling, pain, trismus, swelling of the neck, difficulty breathing and swallowing, if these symptoms are not there, then you can follow the management advice on 84 to 85, which means this one. Okay. Then management of post-operative dental infection not associated with severe symptoms required. So if it is associated with the severe uh, if it is associated with the severe symptoms, then you just need to refer him to the hospital and follow this advice. But if it is not associated with severe feature, what you can do is drain the pus, address the source of infection, give the painkiller for the pain, and rehydration therapy for the infection. Most postoperative dental infections can be managed by dental treatment alone. However, if the patient is immunocompromised, like he has uncontrolled diabetes or he has a systemic feature, which means he is telling you that he has got fever, then you need to prescribe him antibiotic therapy in addition to dental treatment. If antibiotic therapy is indicated, the regimes for spreading an odontogenic infection, which means if you need to prescribe him antibiotic, then you need to give him the oral antibiotic. Okay. And review him back in 2 to 3 days after starting treatment to check for the response. And even after continuing the treatment for 5 days, he is not responding, then seek prompt dental review. Ask him to come back again. Okay. So there are 3 scenarios that they have provided here. If the patient has severe symptoms, then you are not touching the patient, you are just referring him to the hospital. But if there are no severe symptoms, then you can do these 3 points, which is you can do the active dental treatment and you can prescribe him the medication. But if the patient is immunocompromised or he has systemic features include the fever and tachycardia, sweating, in that case you need to prescribe him the oral antibiotic therapy. All right, so I hope that these videos are really helpful for you guys. And yeah, so that's all. And thank you so much for watching. And please do subscribe my videos and share with your friends. I would be really grateful if you would do that. And thank you so much. I'll see you guys again.